Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up modules. This particular module will be looking at complicated pediatric cases, focusing on biological failure. So we're going to talk about Maria, who was started on ARVs when she was 5 years old on 2008 Bacco 3TC and efavirenz. And now she's 11 years old, it's 2014, and we're taking a viral load at the clinic, and it comes back as 176,321. So what we want to ask ourselves at the moment is there's lots of reasons for an increased viral load in patients. But why is her specific viral load going up at the moment? And we do like to use our ABCD in all our presentations on assessing virological failure. But looking at Maria specifically, if you've got somebody, a child, who's always been virally suppressed, and now suddenly they're 9, 10 years old, and the viral load is going up, the first question you're going to ask is obviously about adherence, and specifically you want to know about disclosure. So we would expect that if you work properly with your parents, that there's sort of a phased process of disclosure happening over the years, but you would hope that by 10, 11, the child has actually been told that they have HIV. But many adults and many parents do not feel confident in having this discussion. And if you haven't said anything, by 10, 11, the child is starting to wake up. Either that something's not quite right, or they've even figured out that they've got HIV. So this is an important question to ask the carer in a child like this where the viral load is suddenly going up. Always remember about infections, deworming, and just checking if there's anything else. Remember, your immune system cannot multitask. Very important as well, by 11-year-old, a girl could start to go through a massive growth spurt, and she might just have outgrown her drugs, so her weight have picked up and she wasn't adjusted as she should have been. And then, of course, drug interactions, very important. More often still family or friends giving her various either supplements or over-the-counter drugs, or maybe even a prescription from the clinic that's interfering. So while we've done our ABCD, we've asked a little bit more, and we discover that Maria's an orphan. She stays with her aunt. The aunt has noticed that she's more taciturn than usual, she's more grumpy, and there's been complaints from the school that she's been throwing tantrums in the classroom. And then when you ask her, obviously with a child outside of the room, the aunt says that she's never spoken to her about HIV. And when Maria's asked about the tablet, she's always been told that she's on TB treatment, quite often a more acceptable diagnosis above HIV. So where do we go from here? And obviously at this stage, one could say the horse is already bolted. We are now having to do damage control. And you either need to make sure that you as a clinician yourself is quite confident on techniques of how to self-engage both this girl and the aunt in the process of disclosure. And if you are not, if you can find somebody that is, be it a social worker or a psychologist, or even a very experienced nurse within your facility that feels confident in being able to address this conversation. Until you've addressed the issues of disclosure, you're not going to be able to improve the adherence. When would we repeat the viral load in this child? And it will depend a little bit on your success with the adherence counseling. In children, we normally recommend between 2 and 3 months, but you want those 2 or 3 months to be a period where the child is taking the treatment properly. So you might first try and sort out your conversation around disclosure, and then sit with Maria and aunt to get a commitment to take this treatment, and certainly have the aunt on board to see whether this treatment is still working. So what happened with this particular child? So there was no social worker, and the child was referred back to the clinic. Quite often the doctors write step-up adherence, counseling and support, whatever that may mean. And she may or may not have had good support when she returned to the clinic. As a doctor, you don't see her again until November of that year. And now we're looking back at what's happened with the viral loads since January of that year. So you can see in January there we've got that very high viral load of 176,000. Then April, June and October, consistently staying between 6 and 10,000. It looks that she may very well have started taking a treatment, which is why there is that dramatic drop. But it is a concern when the viral load hovers like that in the thousands. And that's a very typical resistance pattern. But of course, we don't yet know if her adherence has been sorted out. Very importantly as well, I'm also concerned that she's had repeated viral loads done without referral back to the doctor. So ideally, there should be one viral load 2 months later, and if it's high, they should have been sent back to see the clinician. The aunt says that the child is continuing to be withdrawn, but she's now observing her taking treatment every day, and disclosure has actually happened. So where do we go from here? And the challenge is to decide at which point do we say we now have enough evidence that there must be resistance. If you feel you can trust what the aunt is saying and you're confident that the child is definitely taking a treatment every day and has been for the last few months, then the fact that that viral load is not suppressing would make you very suspicious of resistance in this child. So we're now starting to consider changing this child to second line, and you first need to do your baseline bloods. Classically, we'll do a hemoglobin because we're going to be using AZT and the baseline lipogram. And our second line regimen is very similar to the regimen we use for adults. So our Bacava, we're going to be replacing with AZT. They have very different sets of mutations. Our 3TC we keep there to keep that virus crippled. And our Lopinavir ritonavir will be replacing our efavirenz, also a completely different class of drug. And we're expecting this regimen should work very well. Of course, it goes without saying that you can do all kinds of fancy things with the treatment. If the child's not taking it, it's not going to make any difference. And your ongoing process must be on how to build relationship with this child. Remember that preaching, lecturing, threatening are not ways of getting a child on board. And it's very much important to work with positive messaging throughout. So let's see what continues to happen. So remember, we were now in November 2014. We've switched this child to second line. And in March of the next year, in 2015, they do another viral load, and it's come down to 678. And that's pretty much what you would expect to see with second line. As a matter of fact, you'd expect it to be suppressed, but you would expect a nice dramatic drop in the viral load over 6 months. That might be a blip at that point, but you've just changed the child to a completely different regimen. And the regimen in 90% of cases should work completely. What we see in practice is that a lot of patients on second line don't suppress at 6 months, most commonly because the reasons that made them fail first line in the first place has not yet been addressed. So when would you repeat a viral load? With a viral load of 678. She's on second line, the viral load is under 1,000, so we can repeat happily in 6 months' time. Of course, what happens in practice is that the viral load was only repeated a year later, and the viral load is now 23,452. So at this point, Maria has been on ARVs about a year and 4 months. If you've got somebody on second line and still on second line relatively early, not suppressing, your first concern is going to be adherence. We expect it to take a very long time with consistently poor adherence for a patient to be developing resistance to Lopinavir ritonavir. And so that is a very suspicious viral load for adherence. So at this point, of course, we're still working with step-up adherence, and you're still going to have to work with clever ways to help bring the child round to engaging in treatment without feeling criticized or attacked. Not such an easy task. We will obviously need to repeat the viral load, and as she is now on second line, you can quite comfortably repeat the viral load 6 months later. This does happen in September of that year, and it's now 67,543. And you can see that viral load is simply not settling. And we're not sure at this moment in time. It's already been creeping up since March of the previous year. Is this still just an adherence issue, or are we starting to see resistance developing to that PI? So where do we go from here? Ideally, we would have been repeating that viral load again, probably another 6 months later, and keeping an eye on things. But of course, in practice, what happens is that quite often these patients vanish off our radar. And in this particular case, in March of 2017, Maria is suddenly admitted to your hospital. She's now 14 years old, and she's very ill. She's weak, she's pale, there's no specific lymphadenopathy, but she only weighs 28 kilograms. She's got a height of 1.36 meters. No jaundice, no hepatomegaly, but she's confused and aggressive. When you examine her, you find she's got oral thrush. and there's a productive cough and fever that's been ongoing for the last month or so, and when you listen to the chest, there's some occasional rhonchi, and the pulse oximetry is normal. This is a very typical presentation of a patient who has been poorly managed on ARVs, who's been suffering on and off with virological failure, and they now present to your hospital with clinical failure. The problem is with patients who are very immune suppressed is that generally the symptoms are very vague. They don't really point to any specific diagnosis. And the most important thing to remember is there's probably more than one thing going on. So with patients who are HIV negative, we normally try and find that one specific diagnosis. But with somebody who's HIV positive, you must be careful to not start treating only the first diagnosis that stands out. You need to start looking for all the possible problems. And it's very important to think in terms of systems. With HIV patients, the first thing you want to look at is what's going on with the growth. Very important to plot that. In this particular case, she's both stunted and wasted, so she's short for her age, as well as underweight, severely underweight for her age. And that stunted shows that this virological failure has been going on for a while. So her body has been using its resources to fight the HIV. Next, you want to look at the neurological system in this girl because she's presenting with neurological symptoms, and this is also where she's most at risk. This is what's going to kill her if we don't very quickly address it. And we're obviously going to be looking for cryptococcal meningitis, very important. TBM is probably your two top diagnoses to consider in these low CD4 counts. But there's other possibilities. It might be toxoplasmosis, might be bacterial meningitis, PML, HIV encephalopathy, etc. All patients, you need to think of respiratory system, specifically if they have pulmonary symptoms. It might just be a pneumonia, but of course TB is very high on our minds. Also, if they're short of breath and if they've got low oxygen levels, you might think of PCP. And there's various atypical lung infections that could also be contributing. The oral thrush needs to go onto your list and needs to be managed. And of course, the anemia quite often is due to the underlying illness, but it's also important to make sure there's not something additional that's contributing to that. So if you already look at this picture, this is a W stage, HO stage 4 presentation, and we'd be very concerned about AIDS in this child. Your differential diagnosis or your problem list gives you a bit of an idea on what you're going to do for you in terms of testing. And for our blood, it's very important. We need to know what that viral load and what that CD4 is doing at the moment. We obviously want to check what's going on with that anemia, how pale is she actually. The LFTs and the CRP can give us a bit of a clue for disseminated TB. So the LFTs, we can look for a cholestatic picture. Maybe there's something pressing on that liver. CRP may or may not be very helpful. And we need to make sure that her kidneys are still coping. But we also need to look at specific special investigations. And somebody with a neurological presentation like that, if there's no focal signs, the LP is absolutely essential. Now, if somebody's presenting, especially if they either have a positive CRAG or you have somebody who's got a low CD4 count presenting with confusion or headache, you are already thinking about cryptococcal meningitis. And it's very sensible that already by the time you do your LP, you also do an opening pressure. In a patient like that, where the opening pressure is up, that will already give you a suspicion that that might be cryptococcal meningitis. And if they're very sick, you might even decide to start empiric treatment. Do see our modules on cryptococcal meningitis that will tell you more about how you can do an opening pressure with a drip set. Very important, we have to look for TB, and you can do gene expert smear and cultures on any samples you can get. So sputums, FNAs, one can send a urine TB culture, for example. If she's got fever and has got possible disseminated TB, even on the blood, one can do cultures as well. X-ray will be important in terms of the chest symptoms. And I've mentioned there, one can send the urine for a TB culture if you're struggling to get a sample from somewhere else. The challenge is now, it might take a while for us to get a diagnosis, and often a lot of these tests come back very non-specific, especially your TB tests. And a child like that, I would certainly admit, especially with that confusion, or if you are at a primary healthcare facility, you must send the child to hospital. If that opening pressure is high on LP, You might need to consider empiric treatment for cryptococcal meningitis, maybe may or maybe not TBM. TBM can increase your pressures, but it tends to be later in the disease. The cryptococcal meningitis can increase the pressures quite dramatically early on. You want to start some empiric antibiotics in the moment for the chest infection as per your TB guidelines. Make sure she's got good nutritional support as well as hydration, and obviously manage her thrush appropriately. So the results come back on her, and we see that the viral load there is 124,567 copies per mole. CD4 count only 8. The HB is 6.2. And the LP confirms that she's got cryptococcal meningitis. So both on microscopy and she's CLAT positive. Serum CLAT was also done. That's also come back positive. And the gene expert comes back negative, not surprising. So now that we have confirmation that she has a cryptococcal meningitis, we've got to get onto the right treatment. We'll start on amphotericin B and IV and fluconazole according to her weight. And please see my presentations on cryptococcal meningitis for more detail. We're also still worried about TB. Her chest symptoms at the moment are improving on antibiotics. So you might first try and settle that cryptococcal meningitis down and see how she's doing before you make a decision about TB treatment. But we also have to make a decision about the ARVs. So remember, she's on second-line treatment, AZT, 3TC, and lopinavir, ritonavir, and she's got that very, very low HB of 6.2, the very high viral load. This also puts her more at a risk for possibly irising while she's on this treatment for her cryptococcal meningitis. But certainly, you need to try and figure out why is that HB so low. And the tricky thing is to know whether it's the AZT that might have dropped it or whether it's due to this very sick illness patient picture that you see. If it's a macrocytic anemia, that's quite often related to the AZT, where your normocytic, normochromic anemias are more your anemias of chronic disease, but even that's not going to be specific enough for you to make a diagnosis. Certainly at the moment you can't continue on AZT with an HB of 6.2, and you can change it with D4 to D4T until the HB is over 8. And then it will depend on how suspicious you are about that very, whether it's AZT or not, whether you're going to try and re-challenge with the AZT. And just make sure you think of all your possible causes of anemia. So it very well might be the cryptococcal meningitis, or if there's TB, it might be the TB. And as she gets better, you would expect that HB to improve. If it doesn't, there's other possibilities. For example, parvovirus of the bone marrow can give quite a bad pancytopenia. Now it's 1 month later, and we've admitted Maria to our ward. She's much better. Her confusion is settled. Her antifungals has been changed to continuation phase. And she's starting to gain weight. Her HB is now 8.7. Looking back at the history, it did not seem that it was related to the AZT. It seemed to be going down slowly as her illness had progressed. And we've changed her from the D4T. We can just do a straight switch back to the AZT. We've now repeated a viral load 1 month later on this ward, and remember we've been dotting her treatment. The last one was about 128,000, and it's now 87,432. So if a viral load was 127,000, you would expect it to be under 12,000, a drop of 1 log in a month. So that is not an adequate drop, and it's a very good way for you to confirm that she has actually developed resistance to this regimen. Let's talk briefly again about failure on second line. So this child is confirmed failure on second line. There's no drop in viral load despite good adherence. And it's actually very difficult to get that information if you've not admitted and dotted the patient. And that means that she qualifies for genotyping because she's been on a PI for more than 1 year. She's got documented good adherence. And the viral load is more than 30,000 on 2 consecutive readings more than 3 months apart. So interestingly, remember in our lecture on pediatric art, we spoke about the fact that with PIs, we use a viral load cutoff of 30,000. And it's very important that if you are going to do your genotype, that you write the complete drug history on the application form, because they actually take that into account when they're interpreting the genotype. This is just a reminder of when you have your genotype results back, it will all be sent off to the third line committee. And they've got a very clever system of deciding, depending on that genotype result, what third line the patient is going to get. And very importantly, there's therefore no such thing as a set third line regimen. But without even getting the genotype result, you can certainly start to predict what you think you're going to see and which bloods or which drugs we can actually use in this patient. And all patients where we're going on to third line will be going on to darunavir. So the definition of a failure on second line is the fact that they've now failed on their PI, which is usually your lopinavir ritonavir. And the PI that we replace with, that's usually still have some efficacy once you fail on lopinavir ritonavir, is darunavir ritonavir. We can either use TDF or AZT depending on their scores. We generally don't like using abacavir in the third line regimens, and the child probably would have lost that by now. Depending on the age of the child, the tenofovir might be an option. It's one of the few places in children where we do use tenofovir, and the challenge mostly being preparations available. We certainly will keep the 3TC to keep that M184V going. Remember, it will cripple the virus and helps the other drugs to work better. We will add in, if needed, depending on your scores, integrase inhibitor. It used to be raltegravir, but at the moment we do have dolutegravir available for both our adults and children. And then if we see that there's actually quite a lot of resistance or against many of these drugs, we might have to also add in etravirine. But most important is that your quality of counseling for the adolescent is absolutely essential here. I would strongly recommend you look at our online module on adherence. For this, counseling is more of an art than a science, and we do stand the risk of actually making things worse, not better. It has to be respectful and open communication. It has to be patient-centered. You need to help her set her own goals, and you need to help her analyze and understand why she's struggling to take treatment. And there's a worksheet attached to our adherence counseling modules that you can use to even help with that particular analysis. Very important that you create your treatment plan together, and if possible at all, always bring her back to the same providers. So if you've created the plan with her, try and book her in on days when she will definitely be able to see you. It's very important to remember that it's not what you say, but it's how you say it. We want to try and increase the child's self-efficacy, and we want to help her build emotional intelligence. Thank you very much for the input from Dr. Lochin from Frere Hospital and to PEPFAR. Do see our next little module as well that will be focusing on neonatal art.